Hey, welcome to another episode of Talking with Docs. I'm Dr. Paul Zalzal.
And I'm Dr. Brad Weening.
And I'm Dr. Anita Grewal.
Dr. Anita Grewal is a family physician, an endangered species in these parts. Very hard to find one. We're so lucky to have her here. Thank you so much. Family medicine, you got to know a bit about everything.
Ooh.
I respect family doctors so much because they have to know a bit about every body part, every system. We know a lot about like one or two things, but these guys know a bit about
Jack and
everything.
Jill of all trades.
Yeah,
right.
So thank you for being here. And today we're going to talk about
Diabetes.
So you went to your family doctor, you had some screening blood work done, your sugars are high, which isn't making you feel very high. So
No, it makes you pretty lousy. So maybe I'll speak to the fact just quickly around screening for diabetes. So it varies depending on where you are, and the guidelines, the Canadian diabetic guidelines probably suggest a little something different than what I naturally do, but I really push for annual checkups. So I have my patients come in annually, and I feel like it's, once a year is not a big deal considering that you go to get your car checked probably 3 times a year, and you deserve it. So you
Starting at what age? Sorry to interrupt.
I push that message all along.
Like 25? Okay, sure.
Well, when you're a child in development, moms bring in their kids easy peasy
Sure.
because they are checking for growth and their developmental stages. When they're a teenager, it's the whole, risky behaviors and checking and screening. So we lose them sort of in their 20s to 40s, and so I just push that message to hopefully keep them coming and get in that habit. And you want to think of it in this preventative way. So I'm coming in to have this tune-up to check all the things that I can and be proactive and preventative, right?
nice. Once a year, I love it.
Yeah, once
Okay.
a year. So you come in for my patients starting at 40. This might be controversial, but anyways, I do this at 40. I start checking their cholesterol profile and their sugars and their kidney function as well.
Okay.
So typically what happens is a patient will come in after a physical because I've called them back and they've got a slightly elevated sugar, and I'm pretty proactive. So if it's showing at risk or even pre-diabetes, they get a phone call and they come in and we talk about it because it's a good opportunity to start working on what you can do early.
And when you say at risk or prediabetes, depending on the number, essentially.
Exactly.
Okay, so
How
what is it?
elevated?
What is diabetes?
So diabetes is basically insulin gone wrong, let's put it that way. So your body makes insulin in the pancreas, and that insulin helps the sugar get uptaked into cells so that it can be used. Sugar, of course, being the main fuel for your body. So you need that sugar to be going into the right places. When you don't have insulin working properly, so in diabetes, particularly type 2, the insulin isn't received by the receptor. So there's a resistance, is how we call it, insulin resistance. We're not clear, the science isn't clear on where that resistance exactly is coming from, where in the receptor communication, but let's just call it the signal for the cells. It's not sort of getting that signal properly.
Okay, so my keen medical skills tell me that if there's a type 2, there's a type 1.
Yeah.
So let's go through type 1 and type 2 diabetes.
Perfect. So type 1 is you don't have insulin. So this is considered, in this case, it's more of an issue of inflammation. We think it's related to an autoimmune condition where your pancreas and the cells that produce the insulin are being attacked. So you lose out on that insulin, so it's not available to do its job. In type 2, like I said earlier, the insulin is not, the message there is resisted from the insulin. And then over time, actually, the production of insulin also goes down.
Thank you, Banting and Best.
Yeah.
Yes.
Insulin discovery. Okay, so there's type 1 diabetes, type 2 diabetes, and far more common, especially in westernized culture, is type
2.
Type 2, so way more common, and it's about
90%. So 90% of all diabetics are type 2. So this is where we really need to put some focus. And in terms of the healthcare dollars that are spent managing all the complications, it's huge.
It's easier to deal with in the front end, for sure.
Yeah.
So when someone comes into your office, they might feel totally normal. Their physical exam might be totally normal. The only abnormality may actually be their blood work.
Correct. I think, particularly in the community that we work in, I think it's affluent. People are very proactive about their health. So I'm often picking up it early, so before symptoms. In some other environments that I work in, I do have the opportunity to pick it up late. And so those are where you see some of those classic symptoms that you might read about, which you have the excess thirst, the excess urination, and blurred vision and fatigue. I think those would be your top 4 sort of symptoms that people describe.
I'm gonna go get my blood sugar checked.
I remember always the joke on the ward where you dip the finger in the urine, you go, oh, the urine's sweet, must be diabetic, but you really didn't. You didn't.
No.
Ah, that's tricky.
Don't do that.
Don't do that.
Just get your blood work
Right,
done.
get your blood work done. So those are the common symptoms. So in the early phases, then you have the elevated high sugar. They come in to have the second follow-up chat with you. What are we gonna do? What are we gonna talk about?
So depending on what your blood work showed and where you sort of sit in the blood work reference ranges, like I said, you could be at risk, so it's a little bit early, pre-diabetes, and then diabetes. Depending on where that is, we'll run through those numbers and talk about what we need to do. So let's assume for this video that you're full out diabetes.
You got diabetes.
You've
got the sugar diabetes.
You're in the right number range and you have it. So usually that's pretty much a shock, just like everything else that you might tell a patient. It's a bit of a shock and they blur out. And so we have a little bit of a dialogue. I tend to do 2 visits, and I think one for that problem in terms of patients just having to register the news, but also to make the clinical diagnosis, 2 separate blood work are actually recommended, and I agree with that. There's a lot of implications for labeling somebody as a diabetic, insurance, etc.
Sure.
So if you can do 2. So the first visit, I usually actually give them a second rec, and we repeat it in 2 to 3 weeks. I say, let's do another one. And then they come back, and I say, in the meantime, I want you to go, I'll give them some resources to read around.
Like this video.
Like this video, yeah. They can do that certainly. And then they come back on their follow-up, and we decide then, are they diabetic? If that's indeed the case, then we need to start thinking about what do they need to do for treatment.
Okay.
And what do we do for treatment? Okay, my sugar's high. What have I got to do? I want to get my sugars under control.
So there's a lot of issues around here. I think patients, we talked about this in another video where there's myths. And so the idea of getting on treatment is a challenge. Medications aren't always sort of looked at keenly. And they might resist that idea. So, I balance that with our current guidelines suggest that you need to get your sugars down as soon as possible, right? So you're thinking about that sugar's floating around, it's harmful, it's going around and causing damage. So the faster you can get your sugar down to target levels, the better.
So you can't say, okay, we're gonna give it 6 months just to kind of see how it goes. You're like, if it's high enough, you're like, no, we need to deal with this right now.
I have to say, in the past, I would have sort of given them a little bit more time to adjust, but more and more I'm pushing for them to get on treatment.
Because of the consequences.
Because of the consequences. Yeah. And sometimes I think there's that sort of like laxity of just making that call.
Yep.
So the first things that need to happen are, are we in a range that we need to be on a medication? So that takes a lot of sort of dialogue there in itself. But there's really some other important things that you need to do, which is lifestyle, right?
Lifestyle, always. We always start with lifestyle in almost all our treatments.
I think that's the first key one that you should do. It's safe. That's the safest, right? So, and in this case with diabetics, the sort of risk factors are being overweight, having a high blood pressure that's not treated or controlled, not exercising. Those factors are independent risk factors for other things, like cardiovascular disease. So if you can target them and trying to target your sugar, you're doing yourself a lot of good.
So exercise more.
Exercise more.
Eat healthier.
Eat healthier.
We tell people that all the time. When we say eat healthier, we don't just necessarily mean eat less, but eat less might be part of it. But probably eat different foods. So you're saying less processed food, less sugary foods, less fat food.
Correct.
But you don't have to give up Halloween trick-or-treating necessarily if you're diabetic, which we talk about in another myth video, but limiting the amount of sugar that you have.
And you can sort of help patients along as they get more comfortable in how do they eat. This is a really huge topic, I think, in general, but for diabetics, it's challenging. So in that first or second visit, setting up with a diabetes education center, so we have one here at the hospital, is really useful. They get to spend more time. They get to have a little bit more resource around paper sheets, web resources, the diabetes videos. The videos on the diabetes guidelines site is actually pretty phenomenal. They're interactive. So all the information that you can get to sort of like make yourself feel more comfortable, more confident in how you're going to deal with this.
Love it.
Okay, lifestyle and then medications, basically for treating your elevation. And now, what's the big deal? What's the big deal having sugar? Like, let's talk about a bit of the sequelae of diabetes, some of the things that can go wrong if you've had high blood sugars for a long time.
So the sugar, when it's going around in your system, it attaches, I'm going to simplify this, to the proteins on the cell, of the blood cells of the arteries, okay? So let's think about this. So sugar, heavy molecule, traveling in your bloodstream, attaches to a protein that makes up the walls of the arteries.
Okay.
Okay? We have small arteries and we have bigger arteries. The small ones are significant places like your eyes, your nerves, and your kidneys.
Right.
Okay, and those then follow through on those complications that we get, right? So loss of sight, kidney failure, and loss of sensation, and people that run into trouble with ulcers in their feet. That all follows from those little arteries being affected. The bigger arteries would be things like for your cardiovascular system, like your heart, your brain, and those then lead to things like heart attacks, strokes.
Death.
Yeah. So not having that sugar floating around and having the opportunity to attach on and ruin those arteries, that's what we're trying to do.
Sure.
Okay, so sequelae, things like you said, eyes, your kidneys can get affected, your nerves can get affected, so you have diabetic neuropathy, diabetic retinopathy, diabetic nephropathy, your kidneys get affected. We see that as orthopedic surgeons where we see poor vasculature in the lower extremities because you've had diabetic vasculopathy, your vessels aren't working good, you have poor circulation, and that's a big deal for us when we're doing surgery on the lower extremities, for example, because that's going to delay healing, increase the risk of infection and stuff like that. So for us, as surgeons, when we see someone has a history of diabetes, if they've had it for a long time, especially poorly controlled, we worry about these secondary things because it might interfere or increase the risk of a surgical procedure, not just the lower extremities, any surgical procedure for that matter.
Yeah.
And so think of diabetes, it's a sugary disease, but really it's a vascular disease. It's a problem with your blood vessels that is the main issue.
I kind of describe it to patients like it's the plumbing, right?
Yeah.
The plumbing goes everywhere, and you're now targeting your plumbing that feeds all the other important organs. So you can't do that.
That rings close to home because we just had a broken toilet at home, and believe me, it cripples the
And it
household.
is hard to find a good plumber.
Well, luckily I had a patient who's a great plumber. He was kind. That's
Awesome.
another video.
Awesome.
That is an excellent summary of A to Z for diabetes. So if you like this video, please like it, subscribe to our channel.
And remember, you are in charge of your own health and your own blood sugars.
Thanks to Dr. Grewal for joining us again.
Thank you so
Thanks for
much,
having me.
Dr. Grewal.